This webinar is a portion of the Wisconsin Pharmacy Quality Collaborative 2018 annual meeting presentation entitled Serving the Underserved, Celebrating 10 Years of Making a Difference with WPQC. Jen Fody, a clinical pharmacist from Aurora, will present some of her impactful work she and her team are involved in. Jen began her pharmacy journey by attending Concordia School of Pharmacy and continued by completing a PGY1 residency at Aurora Healthcare Metro. Her passion for teaching in a team environment allow her to excel as a WPQC certified pharmacist at Aurora. Please listen and hear how Jen utilizes WPQC in her pharmacy practice.
Hi, my name is Jennifer Fody. I'm a clinical pharmacist within Aurora Healthcare. Currently, I split my time between working with patients in the medication management clinic at Aurora Sinai Medical Center and staffing in the outpatient pharmacy at Aurora St. Luke's Medical Center in Milwaukee. Through this presentation, I plan to focus my attention on integrating WPQC into the ambulatory care clinic setting of the medication management clinic at Aurora Sinai Medical Center. I have nothing to disclose in regards to the content included within this presentation. Through my portion of this presentation, I plan to cover the services provided within the medication management clinic, explain the proportion of WPQC patients that are seen in clinic, outline our WPQC clinic workflow, highlight disease state outcomes from WPQC services, share some WPQC patient testimonials, and then finally I'll discuss some positive opportunities that have really helped make WPQC successful within the medication management clinic. The pharmacist-led medication management clinic is a part of the Family Care Center and internal medicine clinics at Aurora Sinai Medical Center. A collaborative practice agreement is in place within these clinics to allow our providers to refer patients to our clinics to assist in the medication management for patients with type 1 or 2 diabetes, hypertension, dyslipidemia, heart failure, and tobacco use. Providers also have the ability to send referrals for a wide array of different comprehensive medication reviews, either the general all-inclusive medication reviews or disease-specific medication reviews. This chart demonstrates the breakdown of patients seen for disease state-focused comprehensive medication reviews and general comprehensive medication reviews within the medication management clinic over the last year. As you can see from the chart, 23 out of 90, or approximately 25% of patients that are seen in the medication management clinic are WPQC patients. As you can see towards the top, in the top row, most of our referrals do come for our diabetes-focused medication management and comprehensive medication reviews. This chart demonstrates the breakdown of patients that have graduated from the medication management clinic and have reached their clinic goals as set by the referring provider within the last year. As you can see, approximately 35% of patients that graduated from their medication management program within the last year were WPQC patients. This slide outlines the general clinic workflow for all the patients that are seen within the medication management clinic. All patients that are referred to the medication management clinic through a referral sent through the electronic medical record from their provider. During clinic appointments, we focus our attention on medication and lifestyle changes, evaluation of laboratory parameters, along with any necessary pieces of education. A progress note is documented for each patient encounter, which then requires a co-signature from the referring provider as a means to keep the provider within the patient's care. Any follow-up appointments and duration to follow-up appointments are generally patient-specific. Now, there are some slight differences in clinic workflow between patients with WPQC and those with commercial insurance. For our WPQC patients, DAPO authorization must be obtained for the pharmacist to meet with those patients. The clinic pharmacist then provides the referring provider recommendations if therapy adjustments are necessary, and the referring provider is then the one to make those necessary therapy adjustments. The WPQC patient encounters are billed through the Forward Health portal, and these patients are really only limited to meet with a pharmacist 4 times in 1 year. Now, for our patients with commercial insurance, authorization is obtained through prescriber referral within the scope of the clinic collaborative practice agreement. If therapy adjustments are necessary, the clinical pharmacist is able to make those adjustments within the scope of the collaborative practice agreement. Commercial insurance encounters are billed through hospital coding within the electronic medical record. And then finally, most patients with commercial insurance have an unlimited number of appointments where they're able to meet with the clinical pharmacist. Within the last year, we made over 600 pharmacotherapy recommendations within clinic. This pie chart demonstrates those interventions, and as you can see, over 60% of interventions made involve medication therapy adjustments, whether it's dose changes, medication additions, medication deletions. This chart demonstrates the type of interventions that we made within the last year within the medication management clinic, including provider acceptance rates in the far right-hand corner of the far right-hand column of this chart. Within the last year, 98% of medication therapy recommendations made were accepted by our clinic providers. The next few slides outline average disease state outcomes of patients seen in the medication management clinic within the last year. I'm going to focus on the outcomes made with our WPQC patient population, which is outlined in the bars located on the left side of the graphs. The bars on the right side of the graph indicate average disease state outcomes for all patients that were seen in the clinic within the last year. The green bars represent average baseline data, and the blue bars represent our year-end average data for those patients. For patients with diabetes, as you can see in this chart, the average baseline A1C for our WPQC patients was 10.9% in comparison to the year-end average of 8.3%, showing an average 2.6% reduction in A1C for our WPQC patients. For patients with hypertension, the baseline average blood pressure for WPQC patients was 186/98 millimeters of mercury in comparison to the year-end average of 134/80 millimeters of mercury, showing an average blood pressure reduction of 52/18 millimeters of mercury for our WPQC patients in the last year. For patients with dyslipidemia, the baseline average LDL for WPQC patients was 141 milligrams per deciliter in comparison to the year-end average of 82 milligrams per deciliter, showing an average LDL reduction of 59 milligrams per deciliter for WPQC patients. And then for patients with tobacco use, the baseline average number of cigarettes smoked per day for WPQC patients was 8.5 cigarettes per day in comparison to the year-end average of 7 cigarettes per day, showing an average reduction of 1.5 cigarettes per day for our WPQC patients. The next few slides, I would like to share some patient testimonials with you that highlight the complexities of this patient population and the importance of providing WPQC services to them. Our first patient, MD, is a 69-year-old African-American female who was referred to the medication management clinic for type 2 diabetes. Upon referral, her baseline A1C was 11.6%. MD was already pretty familiar with using the insulin pen, as she'd been using the insulin pen for approximately 3 years already. This patient's A1C improved from 11.6% to 7.7% through insulin titration and dietary changes. After meeting with this patient for approximately 4 months, patient's A1C jumped from 7.7% to 11.7%, with blood sugars ranging between 400 to 500 milligrams per deciliter. Continual dose titration without any effect on blood glucose led me to inquire patient's insulin pen technique. Patient appropriately prepared her insulin pen as we had originally educated her, but I noticed as she was delivering the insulin, instead of pushing the button at the end of the insulin pen to deliver the insulin, she twisted the dosing dial back down to 0, basically indicating that she had not been delivering any insulin to herself at all this entire time. Since patient's insulin doses were titrated up pretty significantly over the course of 2 months, I was forced to start her insulin dose from scratch using weight-based dosing and titrating to effect. Patient was re-educated on appropriate insulin pen administration technique, including teach-back method, to verify proper understanding. Now, MD's most recent A1C is very close to her goal with an A1C of 7.2%. Our second patient, JG, is a 57-year-old African-American male who was referred to the medication management clinic for type 2 diabetes, hypertension, and dyslipidemia. Patient is a poor historian and was on a large assortment of medications for his chronic conditions. As a means to gain a better understanding of his healthcare needs, I requested that the patient bring in all of his medication bottles to his appointment. As I was reviewing this patient's medication bottles, I noticed that the patient had been taking fenofibrate, gemfibrozol, and atorvastatin. According to the patient's medical record, gemfibrozol was discontinued and replaced with fenofibrate 3 months prior. The patient explained that his outside pharmacy continued to fill the gemfibrozol using their automated refill system, and he continued to take it because it was being filled by the pharmacy. Patient's primary care provider was never contacted to inquire about prescribing both the fenofibrate in addition to the gemfibrozol. Now, during this patient consultation, I explained the importance of using one pharmacy to prevent drug interactions and potential medication events in the future. Before the patient left clinic that day, I influenced him to have all of his medications transferred to the pharmacy within the clinic building. Patient has since enrolled in the medication sync program to allow for more convenient pickup for his prescriptions, along with the bubble packing services that we're providing to help enhance medication compliance. Our final patient, MM, is a 53-year-old African-American male referred to the medication management clinic for type 2 diabetes. MM's baseline A1C upon referral was 9.1%. Initial interactions with this patient demonstrated limited health literacy. After working with this patient for a few months, his A1C jumped from 9.1% to 10.6%, despite continual insulin dose titration to help reach therapeutic goal. During one of patient's appointments, it was determined that he was storing all of his insulin at room temperature, including his unused insulin pens. Due to inappropriate storage, his insulin lost its efficacy, causing the patient's blood sugar levels to rise despite continual dose titration. Not only did we have to provide education on appropriate storage requirements for patients' insulin, but we also redesigned his insulin regimen from scratch using weight-based dosing and titrating to goal. Now, MM's most recent A1C is currently within goal with an A1C of 6.9%. Now, we have a second situation which arose with this same patient, MM, involving running out of his test strips early and unable to pick up a new prescription for test strips because it was too early. It was determined during one of his appointments that he was skipping his mealtime insulin due to his inability to test his blood sugars before meals because he didn't have any test strips. So why exactly was MM running out of his test strips too early? During one of his appointments, it was identified through a glucometer download that the patient was testing his blood sugar every 1 to 2 minutes after a hypoglycemic reading until his blood glucose was above 100 milligrams per deciliter. Essentially, this patient was using 7 to 8 test strips every time he had a low blood glucose. It was determined during this appointment that the patient did not understand the concept of time and couldn't tell the difference between 1 minute, 5 minutes, or even 15 minutes. So the patient was running out of his test strips early due to an unnecessary overuse of test strips because he didn't know the difference between 1 minute and 15 minutes when he had hypoglycemic readings, causing him to skip his mealtime insulin due to not knowing how much insulin to take without actually testing his blood sugars. So an extensive amount of time was spent with this patient providing education on basically how to tell time and the concept of time for him. As a conclusion, I would like to share a few opportunities that are utilized in the medication management clinic, which have helped to make WPQC more efficient within the clinic. Both student and resident involvement have really helped to bring new perspective and voice to this patient population and help promote clinic-based MTM interventions for our learners. Multidisciplinary team involvement. The team-based approach among the Family Care Center and internal medicine clinic providers and caregivers have really allowed for extensive collaboration of pharmacist-recommended interventions. Having a pharmacy within the clinic building has also allowed us to expand on services provided to enhance medication adherence through bubble packing and cost savings programs. And finally, the new hypertension clinic, which has opened within the internal medicine clinic, has allowed us to work with patients through providing hypertension-based comprehensive medication reviews. Within the hypertension clinic, we evaluate patients' medication lists, meet with patients to determine accuracy of the medication list, provide education on medication therapies, and then finally provide therapy recommendations. Thank you so much for allowing me to share how we integrate WPQC into the clinic workflow of the Medication Management Clinic at Aurora Sinai Medical Center. Please let me know if you do have any questions. Thank you.